Well, speaking of marijuana, you brought it up, Brian brought it up. What do you guys tell patients? Because cigarette smoking, clearly, we say you should not do that creates higher risk, more complications, failing medications, blah, blah, blah. What are you guys saying about marijuana as a personalized treatment for Crohn's?
When it comes to marijuana, I mean, we get this question all the time. Personally, my approach is to, I don't necessarily recommend marijuana from a symptom standpoint. I think many patients do feel better when it comes to certain symptoms, abdominal pain, diarrhea, increasing appetite. And so it can be beneficial as a symptom supporter. On the other hand, there's no evidence that marijuana actually improves inflammation. Has not been associated with outcomes in IBD. There's a couple of small trials that really have not demonstrated improvement in inflammation. And so I want to make sure that patients really understand that if they are using marijuana as an adjunctive therapy or as an adjunctive treatment, it's purely for symptom control and not for disease control.
So Gil, you're right that data is really limited, but it's interesting that the Cochrane review that did analyze the trials actually showed no efficacy, and actually what surprised me was the point estimate. Well, it was actually statistically significant for adverse effects, was in the wrong direction. So, I think it's something you can say to patients that really there's not science. We need to treat your inflammation, and this really, there's not strong evidence for this.
And to that same point, I mean, often, there are patients who want, maybe already smoke marijuana and they just feel like this is a good justification for it. But I think most patients just, like, as everyone here, you hear about it, it's legal, all these beneficial effects, and they're wondering, can this help? And I actually try to use that as an opportunity to understand exactly what are they trying to fix with the marijuana, and kind of to the points I brought up, because for the most part, people are actually trying to fix a symptom, right? And so they're just reading all the things that marijuana does and feel like that's often a way to improve it. So I think that's a good opportunity to either change therapy, do other diagnostic testing.
So I want to clarify for our audience. So Brian, when you say adverse events, those adverse events, I imagine, are symptomatic things, not surgery, strictures, flares.
It's both. It was
both.
Worsening disease, okay, and adverse events such as nausea and other things.
So are you on the side of don't use it, don't mind if you use it, or yes, I think it's okay?
I mean, I don't care very much. That's very Canadian.
Sure.
And but having said that, I think the problem is it's much like 5-ASA therapy for Crohn's disease, yeah. Anita. That,
I don't know who does that.
If you're delaying effective therapy, but you're temporizing with something else, you're really not doing the patient a disservice.
Dr. Afzali, in the Midwest, where it is not legal, I think.
5-ASA?
What do you tell your patients about marijuana?
Oh, I thought about 5-ASA. About marijuana, I'd say, so in Ohio State it's not legal, and I am not opposed to them using it, but I definitely don't use it for the purpose of improving inflammation, which is what they hear. They either talk about the marijuana doing that, or the CBD oil is another thing we all hear about, right? That, oh, I'm going to take this to improve my inflammation. That also, I say that's not valid. You still need to be on therapy, but if you want to do this more for some of your symptoms as we get you on appropriate therapy, then leave it.
Can I actually take it back to the whole personalized concept of therapy? But do you think that we're asking the wrong question by trying hard to tease out severe prognosis versus trying to tease out mild, uncomplicated prognosis? Because I think the issue here is, if you look at the natural history, 70%, 2/3 of patients are progressing to complicated disease. And that's 70%. So why aren't we treating patients with, better, more effective therapies up front? That's 70% chance. We are potentially doing something for the natural history. So I think the bigger challenge that we're not asking is, who is that patient who will do well despite 4 serology positive tests? And there were 30% of patients with very positive serologies up front who actually had a non-complicated course. So I think we should be asking a different question. Which patient will have mild disease? And if we probably assume that 70 patients will have a rougher course, we should be aiming for better, deeper remission early on for the majority of our patients. That's easy, and I don't think we need a test for that.
Okay.